So let's get started here. My name is Whitney Nordvold, and I am the program coordinator for the Great Plains Good Health and Wellness Program here at the Tribal Chairman's Health Board. And this is my first week back after my maternity leave, so I'm really happy to be back, and good to see all these well, some faces. If you have a camera, I would like to see you just so I can wave at you, but I'll just wave at you anyways. Just a few housekeeping things. Please mute yourself. It looks like everybody's already muted, so we're good there. It just helps minimize background noise so that we can hear our presenters clearly. If you have any questions during the presentation, just put them in the chat box, and then I'll facilitate them afterwards, or you can just write them down and you can ask them yourself at the end of the presentation. And it's really important to us that you please fill out the evaluation survey. Your opinion's important to us, and we want to make sure that these webinars are useful for you, and I'm sure that the presenters appreciate any constructive feedback that you have for them as well. So with that, we'll just go ahead and get started. Oh yeah, the evaluation survey, I'll put the link in the chat box, but I'll also send out the YouTube link to this presentation afterwards. There will be the evaluation link will also be in there too, so you can fill it out that way. Which reminds me, if you would like to be added to our listserv so that you can be notified of future community health webinars, or if you would like to receive the follow-up email for this webinar, please put your email address with your name in the chat box so that I can get that to you after this. Okay, I think that's it. So the title of today's community health webinar is Community Clinical Linkages in Indian Country. And we'd like to thank Tasha Peltier and Alayna Eagle Shield for presenting for us. Tasha is a community engagement advocate, and Alayna Eagle Shield is the health education director for the Standing Rock Sioux Tribe. Improving health outcomes is a shared goal for many programs, organizations, individuals, and communities across Indian country. Ensuring that we are partnering with community, tribal, county, state, or federal partners is crucial to the success of these efforts. These types of partnerships can reduce duplication, identify gaps in services, draw upon strengths and knowledge of others, and lead to overall more productive efforts. This session will focus on some unique opportunities for community clinical linkages in tribal communities, as well as highlight some key partnerships of the Standing Rock Sioux Tribe. So that will hand it over to you guys, and yeah, get started. Thanks, guys.
All right, thank you, Whitney. Hello, everybody. My name is Tasha.
Oh, sorry, never mind. We just didn't have the volume up in here.
Okay, sorry. All right, thank you. Hello, everybody. My name is Tasha Peltier. As Whitney mentioned, I am the community engagement advocate for an initiative called the Partnership to Advance Tribal Health. And so I work with both the Standing Rock Sioux Tribe as well as the Turtle Mountain Band of Chippewa to work on various quality initiatives and engaging the community in those in improving initiatives within the facilities. And so I'll let Alayna go ahead and introduce herself.
Vidakiapi, Dokushka Umpiha, Alayna Eagleshield Demachiapi, Yuha Chantewasha Napechiusapi. So I'm Alayna Eagleshield. I'm from here on Standing Rock. I am currently the health education director, which basically we work on a lot of different initiatives out of this office, which requires a lot of different grants and collaborations and figuring out who is in the community, who is in the clinical, non-clinical, and figuring out how we can create initiatives and collaborate to create better health for our members. And yeah, so that's what I do.
All right, so I'm going to go ahead and share my screen here. Just give me 1 second so that you guys can see our presentation. Okay, hang on here. Bear with me. Okay. Can you guys see that? Okay, perfect. All right, sorry I didn't have that up originally. So yes, like Whitney mentioned, we're going to be talking about community clinical linkages in Indian country today. So these are the objectives of our presentation. We want to define, first of all, define community clinical linkages. What does that mean? We're going to discuss the importance of those community clinical linkages, explore unique opportunities and barriers that we may face when working in tribal communities, and then also talk about some real-time examples that we have been fortunate enough to be a part of here in Standing Rock through the work that we do together. So community clinical linkages has a few, there's varying definitions. I just pulled a couple out. The CDC defines it as connections between community and clinical sectors to improve population health. And then AHRQ talks about, oh, hang on here. I feel like I need to get that out of the way. They've probably seen that, huh?
I don't think so. I think it's just
okay. Okay. So AHRQ recognizes it as ways to help connect healthcare providers, community organizations, and public health agencies so they can improve patients' access to preventative and chronic care services. So really why we want to look at this is because ultimately we want to find ways to align the common goals of community and clinical sectors. So how can we increase access to needed care, both clinical and non-clinical? We need to look at improving overall health outcomes for our people. How can we work together to make sure that we're meeting the needs of those patients and those community members? And then also promote community involvement and empowerment. Sometimes we forget about the patient or the community perspective when we're looking at just the clinical side. And so how can we engage those individuals in their care, give them a voice, whether they are a patient or just a community member?
And so we start to think about, why is it even important? And we know that there is a master health contract for Indigenous communities that we all fall under IHS, but there are 638 programs that are involved in that, and we're, for some reason, sometimes separated. And so we think it's very important to assist in coordination and partnerships because they can create a seamless system that helps us to access services easier, helps our patients to access services, it helps our community members. And really, we know that it's important to have patient advocacy, because when our patients go into the clinic, a lot of times there's not much follow-up. Sometimes they don't quite know that if they get picked up by an ambulance and they decide they'd rather go off-res in any direction, that they're going to have to foot the bill. And so I think there's a lot of things that our community members and our patients within reservation communities, they don't fully know, and they also don't fully know the different options that are available to them because there's disconnects. And so really, patient advocacy. We also know that there has to be a holistic viewing of patients and their needs, because it's crucial to their overall health and well-being. A lot of times, some of our grassroots community members, such as our CHRs, right, our community health representatives, our wellness programs, our suicide prevention programs, our diabetes programs, they collect data. They constantly see people within their communities. I know CHRs go in to the different communities. They do PCPs. They have all this data that they collect, and they're sometimes the most trusted in our communities. So when CHRs or different tribal programs go into communities or into homes, they're a lot of times trusted a lot more than when they come into the clinic and it's like fast paced, or they come into the clinic and it's a different doctor. And so there needs to be some kind of communication there for when the tribal programs go out and see the patients, a lot of times that doesn't get back to the IHS. And so then there's not that holistic viewing of the patients, and they don't know what they need or what has been met, what hasn't been met. And it also helps to promote communication and reciprocity between the clinic and the non-clinical entities. So when you think about the tribal programs and the clinical programs, they right now don't have a data sharing. They don't have this collection of knowledge and up-to-date system for discussing what our patients are going through. And so there's not there's a lot of times when we talk about reciprocity, I think it's really thinking about how we not only communicate, but then how we can work together, how we can share resources, how we can just figure out what's best for the patient and be able to communicate better. So we also think it's important because it promotes fiscal responsibility and efficiencies. And I don't know if you want to talk a little bit more about that.
Yep, a little bit. So when we look at not only tribal programs and all programs, sometimes it seems that we're trying to scrape by with what we have, and so if you have if the hospital is working on something and then you have a tribal program and a state program all working on the same things and not communicating or not sharing information or not collaborating, that can be really inefficient. And so just really making sure that we do have those, break those barriers down, open those lines of communication so that we're working very, in the most efficient manner that we can, not only to ease that the services for the patient, but also, like I said, to promote fiscal responsibility so that we are getting the biggest bang for our buck, I guess.
And also, I think what goes with fiscal responsibility is we have patient navigators within our communities, but a lot of times they sit at IHS, or it's, maybe, I know at one point they were at the tribal office, but what we've been doing is inviting the patient navigators to come to every single event that we host, because there's so many chances of people enrolling into Medicaid who maybe don't know how to fill out the paperwork, or maybe there's a social worker on the side that they live on that isn't very friendly or expects them to read when they don't, fully understand it. So there's a lot of factors that play into that fiscal responsibility, and a part of it is helping our patients, our community members, to understand that there's the whole health insurance side of it, which whether it's Marketplace, whether it's Medicaid, Medicare, that a lot of times there's a barrier with our people being able to apply for it unless they're, applying for some kind of assistance in addition to the Medicaid and Medicare. And we also believe that it's important because to utilize and revitalize local knowledge and resources. And we can get into this a little bit more, but thinking about traditional medicines and foods and how that plays a huge role in our diet, but also we could tell our people that they should do this and eat this, but then a lot of times our stores and our community centers are telling the patients the opposite. They'll have chips or whatever it is right at the front of the store. And so we can utilize these things, but unless we give them that education and share these resources with them, teach them how to pick plants or whatever it is, that it's always going to be something that is a disconnect from the clinical setting, telling them to do that, and then the non-clinical community side. And then also just meeting the community where they are is very, very vital, because we think about a lot of this for us here on Standing Rock, and I'm sure it's like this for other tribal communities. There's a main tribal, what would you call it? Just the
hub.
Yeah, the main center, which is usually in the largest, district or town or whatever it is for that community. And a lot of times there's transportation issues for our furthest away community from the center location of our main tribal building and our main clinic and everything that, where all the services are. The furthest community is 44 miles, and there's another one that's 44 miles, another one that's 36, another one that's, and so there's all these distances. So transportation is always an issue. We do have our college transportation, but that costs money, that a lot of times, even if it's only $5, sometimes it's hard for us to come up with $5 just right, on a spot when we need to get to an appointment or when we need to go grocery shopping, whatever it is. So transportation's always been an issue. A lot of communities are more rural, some are isolated, some don't ever get any kind of activity. Some we don't even know, you know, what their needs are. Because for here on Standing Rock, there are 3 different clinics. Well, we have our main clinic, we have a clinic in Cannonball that's only, you know, and then a clinic in McLaughlin. So there's a clinic in Cannonball that's only a couple days, and I don't remember where the other clinic is.
So we have 2 other clinics, one in Wakpala. I think they maybe are once a week or once a month. I can't remember. And then Bullhead has a satellite clinic too.
And so sometimes I don't think, or we know that that's not efficient to have a clinic just once a week or once a month, or whatever the times are set up. And so that's an issue. And also just understanding the reading and educational levels and being conscious of that. If somebody is looking like they're confused, I think sometimes we in the clinical setting, it's like there's not enough time. So you just expect them to take it and get help somewhere else. But there needs to be some kind of connection that if there is a patient that needs more time with reading or understanding materials, that there's a patient advocate. And we can't stress that enough about the patient advocacy in Indigenous communities. And then also the disability stigmas, because there are so many people within our communities that are doing work. They are, you know, they do have jobs. Many of our directors have disabilities, have, you know, replaced knees, or have, you know, Bell's palsy, or whatever it is, have diabetes, have any kind of disability. But it's a stigma because you have to, you know, you have to work, you have to take care of this. And so a lot of times, even people within our own tribal programs don't necessarily know how to get help from our clinic. So then that creates an even better understanding of how our patients know, you know, when to get help. So there just needs to be lots of communication, and we need to understand where our members are, our patients are. So there are a lot of unique opportunities within tribal communities. So so we have a chance to retain, revitalize, and promote a lot of times traditional knowledge within tribal communities. We have traditional foods and medicines, but sometimes only a certain few people know, right? And so we have to figure out how to get those resources out there. And I don't know if that's something that the tribal clinics work with the IHS, but we really do believe that there could be some kind of communication and connection there, whether it's YouTube videos, whether it's creating resources or booklets where, you know, people can get them for free and just go look for these certain plants, and it could have like a recipe list to say, well, if you need a salve, then this is what you need. This is a plant you pick. You need oil. You need this, this, and this, and or even thinking of what kind of foods are better. What kind of foods are also hurting, right? So trying to think of how we can really, really utilize our traditional foods and medicines. And also thinking about how not only do we go pick those plants and we go figure out what those are, but also thinking of that land connection as healing and necessary. So we don't just take from the land, that there's even a reciprocal relationship with the land where we put down tobacco, we say prayers, we offer water, you know, we don't just pull out the roots, we cut them, so there's different ways that we have that connection with our traditional medicines and our foods, but also how we keep that reciprocal relationship with the land, because that is what sustains us, that's what provides for us, and it's necessary. Because when we don't have that relationship with the land, then it is something that we just take from, and pretty soon we won't have it, right? And then also thinking about connecting the physical health to the spirituality. I think a lot of times we forget that we forget that they're separate, right? That I think we talked about traditional views of cutting, that when you are hurting, a lot of times it's all over and you can't localize it, but it's a spiritual pain. It's something that it's your brain, you know, it's depression, it's whatever it is. But to us, that's a spiritual pain. And we have traditional, you know, historically, we've had traditional people, there's different walks of life that would handle that type of pain, as opposed to like a Western or a doctor, you know, medicine man. There were different kinds of dreamers that would help us with that. And so making sure that, even though there's physical pain, you can have a cut, you can have a broken bone, there's also a spiritual pain that feels like a pain that's all over your body that you can't localize. And so helping people to understand that and to be able to separate the two and be able to help them figure out which pain it is. And also healing through identity and cultural protocols. And I know, Tasha, anytime you want to jump in, but we talked about healing through identity and cultural protocols, because a lot of times our communities, we kind of get in that where we just, sometimes we know that, we can go to IHS and they're going to give us medicine, or they're going to give us a cast, or whatever it is that they're going to give us. And I think there are other grants that we have. There's a wellness program to talk about suicide. There's different diabetes programs. We have all these different illnesses, but we do truly believe that if we were connected to our identity and we understood those protocols, just like the protocol between the land and the plants and how you reciprocate, you have a responsibility to that too, that there would be better guidance. Because living in communities where sometimes we are handed stuff, sometimes we can just go to the clinic and make us feel better when it could be a spiritual thing, right? So we're in that quick fix society, and we don't always think of those protocols that we need to be turning to. And so that's one. Another one is kinship. I think a lot of times in our fast-paced world too, we forget to look at each other and think of each other as relatives, because we all know how to treat our relatives good. And sometimes when we go into clinics, or if somebody's having a bad day at any tribal building, we could snap and we could make somebody feel like they're not welcome. But I think always being conscious of looking at each other as relatives and taking care of each other as relatives is really important, especially in our clinics and other tribal programs where our people need those. Our people want to come to those, they want to turn to those. And so we just have to be conscious about that. And then also using language as a guide. So we can make being Lakota, Dakota, Indigenous, all of that, it could be visible. We could have language everywhere. We could have phrases. We could have words that describe our spiritual pain versus our physical pain. We could have, that connect to us in different ways. And I think that's why it's so important to think about and to incorporate the local solutions. So when you think about the team-based approach, we have to include tribal programs and our clinical settings, whatever that clinical setting looks like, because sometimes it's urban, sometimes it's rural, but we have to have a communication and a care team, even if it's just a certain amount of people in each of these sites that focus on making sure that there's information being shared, and because it helps to promote communication between the medical and community perspectives. And one of the ways that we're working on that is we teamed up with the American Indian Public Health Resource Center and our Standing Rock Sioux Tribal Health administration program, and we're working on community health assessments to figure out, because that goes back to and I think we talk about it in a little bit, but when you think about equity, at the bottom there, so when you really do think about equity, we talk about equality. Everybody's like, man, we need to be equal. This community got this much money. This community has, 3 stores. Our community doesn't have a store. So when you think about equality, that's not necessarily what is working. It's not working for us, and that's not what we need to focus on, being equal, because every person, every community is different, and they all have different needs. And so to really focus on equity. So how we've learned it when we were in our Master Public Health program, how it stuck with me, because I'm really big on analogies, is that equality is giving everybody a pair of shoes, but equity is giving everybody a pair of shoes that fit. And so for here, we could say moccasins, right? Mm-hmm. But so thinking about the community health assessment, we're currently working on that. And we believe it's so vital because there are 8 different districts on Standing Rock. Each of them have a different need. Some might need more diabetes education and intervention. Some might need more smoking. Some might need more, whatever it is, we want to figure out what that is so that we could be true patient advocates and community advocates and help them create individualized plans of care. And we also want to do that by meeting them where they're at, going to their clinics, figuring out what they need, helping them, knowing what we know about the communities, that we could have a template already figured out. So when we're helping the patients, we could be true advocates and not be guessing, right? So we also think within the tribal communities, it's really important to try to create a monthly calendar, a newsletter, a resource list of all the different programs and their services, whether it's health or tribal programs, clinical, non-clinical settings, so that there's no duplication of services, because there are so many programs within our communities that are sometimes doing the same things and sometimes not communicating with other programs that they could work with. And so a lot of times I think they say that, our tribe is broke. We have, this, we don't have funding, but we do have a lot of funding. We just have to work smarter and share resources and figure out, if I need this for my grant, if I need this for my reporting for my clinic, I could reach out to this program and try to figure out what they're already doing, what I could assist them with, and try to have a flow within our programs, within our clinical and non-clinical settings. And then create avenues for services to be delivered uniformly and equitably to all the reservation communities.
All right, so we talked a little bit about the opportunities. Now we'll talk about some of the barriers in tribal communities. So first of all, we know that there is a sense of distrust, especially with the Indian Health Service healthcare, just because of, historically it hasn't met the needs of our people. We take what we get, and that really creates a very negative thought of that facility. It doesn't, we don't have choice sometimes. We don't feel like we have a say in the kind of care that we receive. So that really it leaves a bad taste in people's mouths, I guess you could say. And so because of that distrust, it all stems back to historic trauma, to unresolved grief, things that we've gone through as a people that are still affecting us today. We talk about funding a little bit. We know that currently the Indian Health Service facilities are extremely underfunded. And so, a lot of times we see that in the care that we receive. So if you have individuals that are wearing multiple hats, trying to provide care, they're not doing it in maybe the nicest manner, or maybe they're just stressed out, it just affects how they deliver care. And so, as end users of that system, we see that played out in the way that they provide their services. And then also a lack of cultural responsive or sustaining practices. A lot of times we hire, out of necessity, we have to hire non-tribal members, or people that are not familiar with our cultural protocols, or what is appropriate in our communities, or what should be choice in our communities. And so that piece is often left out when we're looking at how patients are treated, or how their choice of treatment, I guess, for medical conditions. And so that creates a barrier, whether sometimes it's communication, sometimes it's knowledge and preference. There's some type of a barrier there between that medical team and the patient. And sometimes when you look at these barriers, or you kind of think, where do we start? There's so many issues that are happening in our communities. There's so many things that need to be fixed. Sometimes that can seem overwhelming, and we can think, I don't even want to attempt it. Or, sometimes people just, like I said, they just get hit with barriers. They get hit with, oh, you can't do that. Or, so it makes it difficult. We also have, when I talk about people being underfunded or stressed, it's hard to get those individuals, and rightfully so sometimes, get them to think outside of what they currently are doing. How can you, asking them to do more, asking them to think outside of the box of what they're currently doing, that can be difficult when you're working in an environment that's kind of functioning in crisis mode. Or when you're working in an environment where communication between programs is not typical. So that's scary to some people. So getting people to think see things in a new lens is sometimes difficult. A few ways that, I think you added these ones maybe. Sorry.
Yeah.
You want to talk about those a little bit?
Oh, the restructuring?
Yeah.
Oh, so I just added, talking about restructuring. I think a lot of times our tribal programs, again, are not culturally responsive or sustaining. Some, because a lot of times we aren't including cultural protocols into our work. We're just saying, focus on diabetes, focus on health, focus on this, focus on that. But how do we focus on it in a culturally responsive and sustaining way? So maybe a restructuring where we could have a fluidity between the clinic and non-clinical settings. And then it just goes back to collaboration rather than separation. And then there's a way that our tribal programs that are collecting data could connect with our IHS or our clinical programs that are collecting data and figure out a way to data share.
Yeah, because I think data is sometimes a real touchy subject, or people get real maybe not intentionally territorial, but sometimes it's even fear. Oh, can I share this information? Is it allowed? Am I where is this information going to go? So data sharing is a tough thing, just because there's a lot of approval processes that have to go, especially when you talk about the Indian Health Service or the clinical side of it. So just figuring that out and making sure that you have systems in place so that that information can be shared. People are understanding why you're sharing it. Why do you want to know? Why do you want to see my data? Well, this is why, we have this big picture idea or whatever. Just communicating that stuff will kind of make that easier. And then also the geographic location, as Alayna mentioned, we have our reservation is large, our communities are far apart. And so we have issues related to communities being isolated and maybe not feeling like their voices are heard. It's a big thing that we hear. We also have 2 different states that our reservation lies on. And so sometimes we have the North Dakota, South Dakota dispute, and some communities feeling that one state's getting more of the resources than the other. And so that makes it really difficult. And so communication is extremely crucial in those situations, so that we are explaining to members what we are trying to do and how we are trying to meet the needs of all community members. And then also transportation, like Alayna mentioned before, we have a lot of issues with transportation. We have a lot of our people, that's a big problem for our people. And so that's another barrier that we face. And then looking at various needs per community, just as Alayna talked about equity, making sure that because every community is different. Yeah, we have, different needs, different, even like language. Just things like that. There's different needs in our different communities. Everybody's so unique that we have to make sure that we're looking at those communities specifically and tailoring efforts to meet the needs of those communities.
Well, and then I think it's also important to discuss, like, North Dakota is Medicaid expanded, but South Dakota isn't. So how do we navigate where our reservation communities lie within the, United States government structures? So there's a lot of things at play.
Yeah, because that's a unique barrier that we should have listed, because efforts that can be done on the North Dakota side sometimes can't be done on the South Dakota side, or they're not going to be reimbursed, or, so that really affects the way people function. And if you're not communicating, or you're not, somebody may not be aware of that. So that's a really, really big, important piece. But we know it can be done. I mentioned a little bit earlier that, through our Partnership to Advance Tribal Health Initiative, I've been able to work with Alayna and the various tribal health employees here. There's several different coalitions and groups that are working on things. And so I see it. I see that people are doing the work. People are trying to communicate. It like I said before, it can be overwhelming, but when you have the right people at the table that are wanting to make change, it can be done. And so I think it's really exciting to see some of the things that have been done here on Standing Rock. And so we're going to go into maybe a little bit of discussion on what we can just give some examples of some of the things that we've done. The first thing that I can talk about is the Opioid Steering Committee. So in North Dakota, the governor, there was some state funding available, state targeted response grant money that was available, and they had specific funding that was set aside for tribal communities. And so when our community, when the Standing Rock community received that money, the individuals that were in charge of it said, how are we going to do this work? What can we do to address this opioid issue. And so the first thing that was done was they created a steering committee and really pulling in different stakeholders, because we realized that there was no one expert, no one individual had the key or the knowledge to address this issue. It was new. People were saying, well, what is the opioid issue? What are we dealing with? So there was a huge learning curve for a lot of individuals on that committee, but basically we pulled in different stakeholders. So we had a pharmacist from Indian Health Service that was able to provide us that, the medical knowledge or the real technical knowledge. We had tribal health, including the ambulance service individuals that were part of that team. I was on the team as part of the Quality Health Associates of North Dakota team, and then also various community members. So we just had, like I said, pulling in different people that had different skill sets, different knowledge of what's going on in the communities or across the state or across the nation. It just was a really great partnership to pull all of those individuals together. And what we decided, based on the information that we gathered from that group, talked about, well, what needs to be done? And so first of all, it was identified that we really need to do some education. We need to, people don't, in the communities, they weren't understanding what are opioids? What is that? Why are we getting that? We get them from the pharmacy, so they must be okay, things like that. There was a lot of misinformation, or maybe the need for education in our communities. And so, but we also recognized that we needed to gather some data. So what are we looking at? Do we have, what are we having overdose instances within our communities? How many individuals are being prescribed opioids? How many people are on pain management? So we were able to partner with IHS and look at that, look at what their policies and procedures are as far as their pain management program, and are there areas that they can improve there, and they actually already identified areas that they could make some improvements within their processes. We were able to hold naloxone training. So naloxone, or Narcan, is the reversal medication for overdose situations with opioids. And so we were able to hold some training for first responders, community members, various stakeholders, to be able to carry that Narcan, so that if they came across a situation where an individual overdosed, they would be armed with the antidote to help save that person. And then I'll go ahead and let you know.
And then we also hosted a pain summit, which was called Awicha Wanglake, which basically meant to take care of one's own health. And then we talked about using traditional alternatives to pain management. There was a lot of different things that we wanted to bring to the table. There's a lot of our youth that understand that this isn't, they're seeing, and pill bottles, or they're seeing people sell them. They know what's going on in our communities. So we brought together some of our youth. We brought together our elders. We had Dr. Warren come in and talk about the holistic view and how it's viewed in the medical world. We had, our ethnobotanist here from Standing Rock come and talk about traditional medicines. We even had massage therapists come in, because like we said before, sometimes we don't know how to localize our pain. And a lot of times it's isolation, it's loneliness, and it's not taking self-care. So we had massage therapists come in and provide massage therapy. We had somebody come in and teach Tai Chi easy. And so really trying to focus on pain management, but focusing on self-care.
And then we also, I mentioned before, the need for education. So we were able to partner, like I said, with the pharmacists at IHS, but we also brought in the drug task force, the agency drug task force lead for our area, because they both were able to provide, one was able to provide kind of the pharmacy technical terms on education on the actual prescription medication. The other one was able to provide more of the street use drug, and like heroin and things like that, things to look for. And so we brought them both together we went out to each of the 8 districts on Standing Rock during their monthly district meetings, because we know that's when we can get engagement. That's when people go to those meetings, so that we went to them. And so it was really successful. We got a lot of really good feedback. We actually, they promoted the tip line. There's a tip line for if you know individuals that are illegally using prescription medication. We got a lot, there was a lot of, every time we go out to a district, there would be a lot of information that was shared on the tip line. And that was really helpful, because when we're trying to combat this issue in our communities, we have to know where to go, who's diverting their medication, things like that. So that's helpful to us as we're trying to combat this issue. And it was very well received. There was a lot of questions. You could tell that we had a lot of positive feedback from community members. People are just tired of it. People don't want to see it in our communities anymore, and they want to know what they can do to make it better. And so it was very well received. And then other supports where we did some radio ads talking about, just again, education. We needed to get that information out. We did pre and post surveys at the Pain Summit, just trying to gauge people's knowledge prior to the Pain Summit, see if what they learned, what they liked, what they didn't like. We also were able to send some individuals to peer support specialist training. And we're also looking at creating a resource list for individuals that are seeking treatment, whatever it is that they're seeking to help overcome, maybe their opioid addiction, or if they have a family member that they're worried about. We need to gather and make resources available to those individuals. So I talked a little bit about the naloxone training that we did. This is another example of how important it is to collaborate, not only within our tribal programs, but there's also county, state, and federal level programs that have resources or information that will be useful to us. So we knew that we were able to connect with Custer Public Health in Mandan. They had some state funding as well, and they were able to come and do our first Narcan training in our community, in the 4/8 community, and also give out some free Narcan to individuals that were trained that day. And so once we did that one, there was also an ask, are you going to do more? We had other, security guards at the casino that were wanting training. We had other individuals. We knew that we needed to do another one. And so we scheduled a second Narcan training during the Pain Summit. And we were able to partner with the Alcohol, Tobacco, and Other Drugs program here at Standing Rock, and use that state targeted response grant money to purchase Narcan for individuals that were trained. And that had to happen through a partnership as well. We had to use our pharmacists. They had to be the one to purchase it, and to, we needed that. We couldn't have done that without that partnership. So just another good example of how everybody came together. The IHS wouldn't have been able to pay for all of that. So the grant money through the Alcohol, Tobacco, and Other Drugs program helped them to provide that service. So it's just a good example of how coming together can really make things work.
And then we also had a chance to invite again, Custer Public Health program coordinator, or one of the program coordinators of the Mandan Good Neighbor Project, to come down and talk about the syringe exchange program that they have. It's called the Mandan Good Neighbor Project. They basically provide education. They also have cooking kits, which is kind of, for a lot of people, it turns them away, and it pushes them, because they think that we're promoting drug use, but really what we wanted to promote was harm reduction. Because when we walk around in our communities, so many people see syringes, so many people see empty bottles. There's so many different things in our community. So we know that our children are exposed to this, these, even if it's just the after supplies, that we have to start talking about this, and we really need to focus on harm reduction rather than if our people get Hep C, if our people have any kind of, illnesses or diseases related to any of their any addictions, that we want to be able to meet them where they are. Just like I said when in the beginning, when we talked about meeting our communities where they are and not being judgmental, figuring out how we can help them. Because if we constantly throw judgment, if we constantly belittle them and make them afraid of the law, then they're not going to seek help. We're not going to be able to meet them where they are. So the syringe exchange program, they provide cooking kits, which is basically they provide little tiny spools where you could cook your the drugs. It's all so they provide syringes, they provide the cotton balls, they provide water, distilled water, and this tourniquets, which turned a lot of our people off. But we know that people aren't going to get help if we continue to judge them, and so we really are focusing on prevention and harm reduction. And so there's a limit of syringes they get, and there's also a referral process. So when they come in, they talk to them about, what they're offering them, and they offer them treatment services. They talk to them, they give them referrals, so they help them get into treatment programs. It's not like they're just giving this for free. They have to have education. There's requirements by their funders as well. And so
one of the things, sorry, I know we're running out of time, but I think one of the things that, she shared with us is that they're also developing relationships. So these drug users maybe don't have anybody that they talk to other than their friends that are using drugs. And so just that interaction with somebody who's not a drug user, who maybe has a positive outlook on life and can help them to think that maybe, they've had individuals that said, okay, it's time to quit, or, I'm ready to be done. So yeah, that was pretty exciting.
Okay. I was wondering where the traditional medicines at?
So then we just wanted to talk about next steps. So we really would like to create efficient collaborations and communication between the clinical and non-clinical entities on Standing Rock. And that I'm not sure what that looks like, if that turns into MOUs or MOAs between, and I know there are some in place, but really defining and looking at the fine print of what that looks like and how we actually, according to federal and any kind of laws or restrictions, that what that looks like for us to be able to work collaboratively together in a more efficient way. So if that, whatever that looks like. And then also we really need to think about what Standing Rock could do, or, for our community, but health codes. We don't have health codes in place right now, but there are some other Indigenous communities that have already done it. They've already created health boards. And so how do we learn from these communities of what worked, what didn't work? How can we create that? And even if those codes and health boards, if they are working right now, so we want to learn from other communities. We want to figure out the best way that we can have reciprocal relationships. We want to figure out what the best solutions are for having communication and collaboration for the sake of our people and our communities.
All right. Okay, that's all we have. So if you guys have any questions, comments, concerns, now would be a time to bring them up.
You have 2 minutes. Go.
Yeah.
We have 2 minutes.
Does anybody have any questions for these guys? Thank you so much for all the information and for so many really great examples of why this is such an important tool to be using in our communities. Well, I'll ask a question. What is one of the large, what is one of the major challenges that you've had doing this kind of work, and how have you been able to overcome it?
I think one of the major challenges for us is having clinical professionals sign off on things when we need them, or have them to support us when we're trying to initiate a different type of treatment or idea. I think it's that for me, that in my opinion, that has been one where we need somebody on the clinical side that supports us and could write off on some things that we really do need and that have been proven and evidence-based.
And also, I think along those same lines is a lot of programs funding and is based on grants, and a lot of times it's always pushing evidence-based practices or evidence-based and data, collecting data, and that's something that's difficult for us. I think it's difficult to sometimes evidence, nationally proven evidence-based practices aren't what fit our communities. And you guys at the health board know that. I mean, you see that. And so that's difficult. That's difficult it's like trying to fit a square peg into a circle hole, it's like, so getting creative in that sense is it's interesting sometimes, I guess.
And also really trying to think of what our programs are working on, and where somebody who's so overwhelmed, somebody who's wearing 20 different hats, how they can delegate and know that it's going to get done. So there needs to be not only a reciprocal relationship, but a trusting relationship, because we really do need to work with each other in good ways.
All right, thank you. Yes, we can totally relate to both of those comments here, and I'm sure our audience can relate to it as well. So, like you were saying, we have the people who are doing the good work are doing lots of good work, and they're spread really thin. So, thank you for that. Are there any other questions before we wrap up?
Hi, can you guys hear me?
Yes.
Yeah.
Oh, well, my name is Stephanie Yellowhammer. I used to work for the tribe here for a SAMHSA grant, and one of our struggles was being a tribal program but not having that linkage to the IHS and the clinician. So I'm so excited that Tasha and Alayna are here and doing such good work. It is definitely much needed. So I was like, man, if only our FPO at the time could have listened to this webinar. I mean, it explained everything that we experience on the tribal level with, working with the providers and whatnot. But I'd like to say, good job, ladies.
Awesome. Thanks, Steph.
Yay, thank you. So would I have a question, I guess, Whitney, or I don't know if anybody else from Great Plains Tribal Chairman's Health Board, Shanna or Tara, or Melita, do you guys have a template for creating, like if there are programs who have either 638'd, their hospitals, he turned it into a verb, did that to their hospitals, or if there's, an IHS clinic and tribal communities that have an agreement to share data, if there's like a template we could share with tribes, or if because I'm all about not reinventing the wheel and doing work that's already been done and just being able to place. So whenever we work on stuff, that's what we try to do. Or like toolkits, but I think that this is a talk that happens in almost all Indigenous communities that I know of, that there's just a disconnect when there really shouldn't be. Our tribal health and our clinical and non-clinical tribal health programs.
So you're asking about a document between like the IHS or a local clinic and the tribal community health department?
Well, I'm wondering if you have one, or if you could create one where we are able to work together without all the barriers. Because there's times where IHS has tried to work with tribal health has tried to work with our clinical, I keep saying IHS, but clinical settings and vice versa, where they're like, I'm sorry, I can't, I want to, but I can't because, it's not up to me. And so I'm not sure what that looks like. Plains could assist in all the tribes doing that.
Because it almost seems counterintuitive, because in my mind, the tribe owns that data. It's health data, but it's their tribal members, it's there. So it's so weird to me that I can't be shared. So do you guys have any ideas, or
this is Melita. Can you hear me?
Yep.
Hi. So we have a technical assistance department here at the Epicenter. And what we do is we try to meet the needs of the tribes that we serve. And part of that includes working with emerging needs. If there's something that the communities need that they don't have, or they want to learn how to do, or learn how to set up, or whatever, we can take that as a technical request, and then we try to decide among our group how we're going to handle this request. It might go to, if we can do it in-house, we'll do it. If we need to employ someone else to help with that, then we can go ahead and do that too. But I think if you can go to our site and kind of write out what you need and submit a request, we'll receive it on this end and we'll try to work on it.
All right, thank you, Melita.
Mm-hmm.
And you can always, in order to follow up on that, you can, I made a note of it, but if that's something that you would like to do moving forward, guys, you can shoot me an email since you have, or, you know, Shannon, since you've been communicating with her, and we can walk you through that, so that that's something that can not just be talked about, but something that we can try to address.
Awesome.
Yes, I'm really talking, guys, and I'm muted. Okay. So that wraps up our time for today. The evaluation link is in the chat box. So if you want to copy and paste that into a web browser and get that filled out, we would greatly appreciate it. I'll also, like I said, send that out in an email. I just want to let you guys know that our next webinar is August 8th, and I'll be presenting on success stories and sustainability planning, why that's important, some examples and some ways to, creative ways to tell your success stories and things like that. I also want to remind everybody that we have our Great Plains Good Health and Wellness symposium coming up. That's August 28th and 29th. We have travel scholarships available, some travel scholarships available, and I'll send out, we have a sign up page for that, right? Like, okay, so I'll include that link in the follow-up for this email too, just so that you can check it out. And we have an agenda that should be coming out here pretty soon for that, a tentative agenda, and that'll be here in Rapid City. Don't forget the evaluation. I'll include that in the email as well. I was wondering, can we get a copy of your guys' slideshow so that I can include that in the follow-up email?
Sure, I'll send that.
Okay, thank you so much. All right, well, thank you guys so much for joining us today, and I hope you learned something new, and I hope you have a great day.
Thanks.